shaman. And we have the femur, mainly the femoral head, neck, and two T1 This is the greater trochanter, and this is the lesser trochanter. So let us first describe a little bit about the bony architecture of the head. So here if you look at the anterior part of the ilium, I'm taking the ilium. Can anyone tell what is the name of this portion? This is very important structure. Please, who is there? Volunteer. What is this projection called?
Anterior superior areas.
Very good. This is the anterior superior iliac spine. And this is the, there is another projection just below it. This projection, what it is called? Very simple. You have told this anterior superior iliac spine. Again, it's a spine. So what is the name of this?
Anterior inferior superior.
So anterior inferior iliac spine. So very good. So these two prominence are very important for us. Okay. Now moving to the next. Then we all know there is a rough area in between because iliac bone continues up to this. Then the pubis bone attaches with this. So this rough area over the close to the acetabulum and where the ischium and pubis they are meeting superior pubic ramus. This is superior pubic ramus. They are meeting. This area is known as. Can anyone tell again? Ilium and pubis. They are joining. Any idea? Please, it may be wrong, but try. Okay, no one is trying even. So this is the iliopubic eminence. That means previously there were two bones, now they are one, and this rough area represents this iliopubic eminence. Now, if we move forward, this portion is the pubic superior pubic ramus. Then this projection is known as the pubic tubercle. This portion is the body of the pubis, and this is the inferior pubic ramus. So again, I am repeating the most of the important bony points around this. First, this is the anterior superior iliac spine. Then we have the anterior inferior iliac spine. Then we can further go, and then we can get the iliopubic eminence. Then it is the ramus, superior pubic ramus. Then we have the pubic tubercle. Then we have the body of the pubis, and this portion is known as the symphysis pubis. Basically, this is not symphysis pubis. Symphysis pubis is a cartilage, but this body of the pubis attaches with the symphysis pubis, and this is the inferior pubic ramus. So, just remember these anatomical landmarks as they are important for this hip joint understanding. Now, there is the socket. Okay. Now, this socket, some portion is bony, but this bony portion doesn't complete the socket. So, there are some cartilaginous portion which lies and anterior and all around the bone, and it makes this like this portion. Okay, so this portion is also covered. They are not like open, but this portion is covered by a cartilage. And what is the name of this cartilage? Anyone? Please try. They are not very difficult questions. They are just I am asking you because you just try to recapitulate because you all know this. I am 100% sure. You have read in your anatomy. Can anyone remember what is this cartilage known as? No one is even trying. So this is the labra. In shoulder, we have seen the glenoidal labra. Here, we are getting the acetabular labra. Now, we have the femur. Now, this portion is the femoral head, and this portion is the neck of the femur. Now we have two trochanters here. In upper limb we have two tuberosities. In lower limb we have two trochanters. This rough area is the greater trochanter. In the posterior limb we will be discussing on these facets as well. But today we will be just know this. This is the greater trochanter and this is the lesser trochanter. And in between this trochanter, there is the intratrochanteric crest. Similarly, posteriorly, there is the intratrochanteric crest. So this much is good for the anatomy for the anterior side. So I'm just showing you whatever I have told. There should be always more points, but most important points we are actually discussing. So again, I'm just repeating for you important points. This portion is the anterior superior iliac spine. This is the anterior inferior iliac spine. Then we have this portion that is known as the iliopubic eminence. See this line, rough area. Then we have this superior pubic ramus. We have this pubic tubercle. Then we have the connecting with the symphyseal surface. This is the body of the pubis. This is the inferior pubic ramus. This foramen, hope you all know, this is the obturator foramen. It is covered by a membrane, obturator membrane, and there are two muscles originating from it. They are known as the obturator externus and obturator internus. Okay, the two muscles are arising from this obturator membrane. It is covered by the obturator membrane. Now, here this part of the inner anatomy that we cannot see under ultrasound, that's a lunate surface. I'm not going into it. This is the fovea, acetabular fovea. This portion is the acetabular margin, and there will be acetabular lamina. So I think this portion you have understood. The posterior portion I am not discussing today. In the next class, we'll be discussing the posterior portion. Now, let us move to the important landmarks of the femur. So let's go closer. As I told, this portion is the greater trochanter. This is the intertrochanteric crest. This is the neck of the femur. This is the head of the femur. And then we have this is the fovea of the femoral head. I'm not discussing into it because this is basically not required for us. This is the trochanteric fossa. This is again the intertrochanteric crest. This is the lesser trochanter. And there are the pectineal line through which the muscle pectineus attaches. This is the gluteal tuberosity, but the gluteus maximus attaches. So this is how is the histology of these two. Now, every one of you have understood the histology portion. I will ask you a question. Otherwise, there is no point. I am talking and you are just listening. Okay. So again, I am asking another question, and this is the last question. Is that what is the name of this bone? Anyone? Bony portion, this area.
Greater trochanter.
That's all. Okay. Now let us move to the other part because now we have understood the bony part. Now we'll be moving towards the ligaments. So bones are connected with ligaments, and three important all the ligaments. It is very difficult to remember. Three important ligaments are very important. This is the anterior sacroiliac ligaments, which is connecting the sacrum with the ilium from the anterior side. Similarly, like anterior sacroiliac ligament, we have the posterior sacroiliac ligament as well. The posterior sacroiliac ligament. Now we have two bony projections. One, this is, I have not told you because it's mostly connected with the posterior part. This is the ischial tuberosity and this is the ischial spine. So from ischial spine to sacrum, we have a ligament known as the sacrospinous ligament. Similarly, from the ischial tuberosity to sacrum, we have another ligament is known as the sacrotuberous ligament. These two ligaments are very important when we will be learning the pudendal nerve block from the posterior side. So remember this anatomy because it will be required. Now, here is the iliofemoral ligament and we have the pubofemoral ligament. So they are actually enhancing the capsule portion and they are forming a bond between this femur and iliac. Now, as we have learned this ligament part, now we have few important bursas. This is known as the trochanteric bursa. Not all bursas are shown in this anatomy 3D. This is the trochanteric bursa, and here we have the iliopectineal. Just remember these two bursas. Other bursas will come to discussion. We will be discussing the other part of the anatomy. Now, I am again repeating. From it is the anterior sacroiliac ligament. Posterior is the posterior sacroiliac ligament. Then from the ischial spine, we have the sacrospinous ligament. From the ischial tuberous sacrum, we have the sacrotuberous ligament. And we have the iliofemoral ligament. And we have the pubofemoral ligament. Just remember these 5 ligaments. Now we have this iliopectineal bursa. And at this point, we are having trochanteric bursa. Okay. Again, trochanteric bursa will be subdivided according to the muscle under which it is there. But now, for now, I am not discussing or not making it further complicated. So, ligament portion, I think you have understood. Now, the most important portion here that we have to remember, each and every step of it, it is the muscles. So, let us zoom and show you the muscles. Now, today, we are mostly concerned with the anterior portion of the hip. So, we will be first knowing what are the anterior muscles. Remember, in anterior portion, the most important are these two muscles, mainly the iliacus and the psoas. They are known as the iliopsoas muscles because they join together and they continue to attach at the same time. And this portion first what forms the tendon, then the iliacus tendon also comes closer to it. So this is the most important muscle of us. That is the iliacus, or sometimes it is called the iliopsoas. This is the psoas major, and this is the psoas minor. But remember, not in all cases we have to differentiate the psoas minor, and we will not be trying to. But the important is the finding the psoas muscle, psoas tendon, and the medial and lateral fibers of the iliacus that we will be able to see in the cross section. So, if we put a probe at this point, say here, at this point, we are putting a probe. Okay, then we'll be able to see the cross section of the iliopsoas muscle. This portion you just remember. Hello, hello, am I audible?
Yes, sir.
Yes, sir. Audible, sir.
Okay. Unfortunately, we had a power cut. So I'm just connected with the mobile network. So it may be a little bit difficult, but we'll not stop because your power cuts are very transient. So let us continue. Okay. Okay. I'm hiding my picture because it is too dark. You won't be able to see me. So I'm just switching off my camera. Okay. But I will be continuing with the section. Now, can you see that clearly?
Yes, sir.
Sir.
Okay, fine.
Yes, clearly.
So let us continue. So, in this portion, first try to find out this is the iliacus, this is the psoas, and this I am just ignoring psoas minor. So, iliopsoas takes origin from the muscles, iliacus, origin from the iliac fossa. So we all know there is the fossa, just we can hide, and this is the iliac fossa you can see. From this fossa, this muscle takes origin, and this muscle gets inserted into the base of the lesser trochanter. Okay, so this actually along with the psoas muscle. So we can see this in that. Now we have other muscles. So from this area, if we go laterally, then we have another muscle. Remember, this muscle under ultrasound we diagnose through a typical characteristics of this muscle is that sartorius muscle is always triangular when we see in cross section. So remember, two muscles are typically triangular when seen in cross section. One muscle is in the upper limb, it is the sternocleidomastoid, and one muscle in the lower part, that is the sartorius. And another very important feature is the sartorius is the longest muscle of the body. So it originates from the anterior superior iliac spine. Remember, initially I am started with the anterior superior iliac spine. So this muscle takes its origin from the anterior superior iliac spine. And this muscle continues long, and they continue, there is no attachment or actually in the femur. So they cover the whole of the femur, then they curves around the back and they attaches in the medial side of the femur, sorry, tibia, in the medial side of the tibia, along with two other muscles. That is the gracilis and semitendinosus. So it is a very surprising structure. That is one muscle from the anterior side, that is the sartorius, one muscle from the medial side, that is the gracilis, and one muscle from the posterior side, that is the semitendinosus, not membranosus, this is semitendinosus. Membranosus attachment is slightly different, but these three muscles, they comes together and joins at the upper part of the medial portion of tibia. And these muscles are known as the pes anserine muscles because their attachment, lower attachment, looks like the feet of a goose. Okay, so that is known as the pes anserinus muscle. So we will be able to see the sartorius at this point, and it is taking origin from the anterior superior iliac spine. The lower attachment we'll discuss the knee, but the upper attachment here will be able to see. As we are going towards the lateral side, okay, from the sartorius to the lateral side, we have another big muscle, that is the tensor fascia latae. So they attaches to the upper part of this iliac crest, and it goes again below to attach into a connective tissue that is known as the iliotibial band. So this is the iliotibial band, and tensor fascia latae attaches with the iliotibial band. And this connective tissue, iliotibial band, continues, and it is again not attaching to the femur, rather again it is attaching to the tibia. Here, so this is the iliotibial band. You must have heard about the iliotibial band syndrome. There is a pain at the lower part of the iliotibial band when it is having friction with the tuba condyle of the femur. And if you go further posterior, we will be having the gluteus medius and the gluteus maximus. Okay, remember gluteus medius is slightly deep and gluteus maximus is superficial. And gluteus maximus along with the tensor fascia latae forms a deltoid-like appearance. Like upper limb, we have the deltoid. In lower limb, we have this gluteus maximus and the tensor fascia latae. And along with this connective tissue, they are quite acting as a covering muscle. Okay, and this is known as the deltoid of Saraput. Okay, now again digging deep, and first what we are doing, we are hiding the sartorius. We have learned about the sartorius. Now we are hiding the sartorius. Now below we can see this muscle. This is the quadriceps femoris, but quadriceps femoris has four components. This is the one of the longest component of the quadriceps muscle. It is the rectus femoris. Now, rectus femoris takes origin from the anterior inferior iliac spine. So, at the beginning, I have clearly told you about the anterior inferior iliac spine, and you can see the anterior inferior iliac spine attaching at this point. Try to remember this anatomy because the same anatomy will be seen in cross section while we'll be seeing the next one. I'm hiding that rectus femoris. And rectus femoris, where it attaches lower attachment, I forget to say, but anyone can tell what is the lower attachment of the rectus femoris? Any one of you? Please. I'll be happy if you can say. Where does it attach? Yes, please.
Patella?
Patella, sir. Upper border patella.
Yes, very good, very good. It attaches to the upper part of the patella. Fine. Because along with the other quadriceps muscles, they bring together, they form the quadriceps tendon, and this quadriceps tendon attaches to the upper portion, the patella. Very good. Now, as I have hidden this quadriceps femoris, sorry, rectus femoris muscle, vastus muscles we are not discussing because they are starting from below, and it doesn't come into this part. That means in the hip joint part, it doesn't come. So below these structures, we can see the neck of the femur. So while we'll be focusing at the head and the neck of the femur, we'll be able to see the iliopsoas over the head of the femur. We'll be able to see the rectus femoris, which I am hidden, which is starting from the anterior inferior iliac spine, and we'll be able to see the sartorius and the portion of the tensor fascia latae. Okay, and if you dig below, here we can see the gluteus maximus in the deeper side of the anterior side as well. Okay, maximus and medius portion also we can able to see, but that deep we do not see, and we do not want to see that, but that's not important. So we will be seeing these structures. Now, today we have the anterior. Yes.
Yeah, there is some echo sound with your sound, and it
Some
becomes
echo
not
sound.
clear.
Some
Yeah.
echo. I don't know how it is coming. Anyway, let me check. Automatically adjust the microphone volume. Let's try. Now it is there, or it is
It's
gone,
better.
or it is still there.
It's
This echo
better.
sound.
Better. No echo. Less echo.
Still echo is persisting.
Less than before.
No echo, sir.
Okay, just 1 minute. I think the connection is now restored. So let us try joining with the Wi-Fi. One possibility could be in the mobile this time. So just 1 minute. I'm again connecting to the 5G connection. Okay, now I'm connected to the broadband connection. Now is it all right, or still it is causing the problem? Hello? Hello?
Sir, it's fine now.
Now it is okay, na? It is because of the quality of the internet connection. I was thinking so. So now I'm connected with the broadband, so it will be clear now. So see this muscle. You have seen the pectineal line over the humerus. Here is also there is pectineal line, and this muscle is known as pectineus. So pectineus muscle will be able to see in the medial portion. Along with, we'll be able to see three adductor muscle at the medial portion. The adductor longus, which attaches to the bony portion of the body of the pubis. If I hide the adductor longus, then we'll be having the adductor brevis. And again, if you hide the adductor brevis, we will be having adductor magnus. Remember, adductor magnus is a really big muscle, and if we hide the vastus as well, you see adductor muscle. This is the whole muscle is the adductor magnus. Okay. And here I am ignoring the adductor minimus because it is not always present and you sometimes not able to differentiate. But see this adductor magnus, how big the muscle is. Okay, and it has two components. The portion which is starting here and connected to the lower portion of the femur. This is the hamstring portion of the adductor magnus, and this portion which is connected with the femur, which is this portion upshaft of the femur. This is the adductor part of the adductor magnus. So it is a big muscle, and that is why it is called adductor magnus. So muscular part here, I think you have understood. Though today we are not discussing about the posterior part, I am just giving you an overview of it. So we have the gluteus maximus, because this is important. Next class it will be required. Then we have the gluteus medius, all are attaching to the posterior flat part of the ilium, and then we are having the gluteus minimus. Okay, so this is the portion of attachment of the three glutei muscle, and under which we can see the deep gluteal muscles from the posterior side. So this muscle which is attaching to the S23 foramina anterior side, and other side it is attaching to the medial portion of the greater tuberosity. This is the piriformis muscle. This muscle is important for us for a condition known as the piriformis syndrome. If we hide the piriformis, then we have another three muscles: camellus superior, camellus inferior, and the obturator internus. Why this is internus? Because it is starting from the internal side of the obturator membrane. As I told, obturator foramen is covered by a membrane that is known as the obturator membrane, and two muscles taking origin from the internal side and external side. The internal side, the muscle originates is the obturator internus, and they just below the spine, they goes and attaches to the same portion, all three muscles, along with the camellus superior and inferior muscle. So these three are the another deep muscles, and this is the quadratus femoris. This muscle is very, very important to identify the sciatic nerve, because the sciatic nerve will be moving over this muscle, and to the block of the sciatic nerve, we take this muscle as a guide. That is the quadratus femoris. I am not going into detail. I am just telling the names because for the next class you will be ready. You will be able to remember the names once you have heard. Again, we will be discussing again and again for this. Now, moving to the nerves. So, not focusing on the superficial nerves, that is not important, but two nerves, they are very important for us. One is this one. Though it's a superficial nerve, but it is common to get entrapped at this point, close to the inguinal ligament. This nerve is the lateral femoral cutaneous nerve. Lateral femoral cutaneous nerve is situated between two muscles that we commonly see. One is the sartorius, and other side it is the tensor fascia lateral. So we usually identify this nerve at this point. Okay, and below there will be the rectus femoris. So we have to track and find out this muscle, this nerve. This is the lateral femoral cutaneous nerve of thigh. And if it is entrapped at the level of the inguinal ligament or below, the disease is known as, I will not say, I will ask you, what is the name? Where there is entrapment of the lateral femoral cutaneous nerve?
Meralgia parasitic.
Very good, very good. That is the midalgia parasitic. And sometimes we have to differentiate it from the radiculopathy. Remember, it doesn't cause muscular weakness, but there is constant pain in the anterolateral side of the thigh. And we need to find out, and we have to do hydrodissection if required. Now, this nerve, I think every one of you will be able to identify. So after asking an equation, this is the femoral nerve. Now, to identify the femoral nerve, we have a closed vessel nearby, that is the femoral artery. and that is very easy to locate, and close to the femoral nerve, we'll be able to identify, close to the femoral artery, we'll be able to identify the femoral nerve, and further medially, we'll be able to find out the vein as well, and then we'll be having the lymphatic. But close to the femoral artery, we have another nerve. See this one. This is the femoral branch of the genitofemoral nerve. So, if there is a pain which is going to the medial side of the groin, and sometimes if the genital branch is also involved, it can come to the partial portion of the scrotum as well. So that is the genital branch of the genitofemoral nerve. Remember, this nerve is comparatively easy to identify. That is the femoral branch of the genitofemoral nerve. But this nerve, genital nerve branch of the genitofemoral nerve is a little bit difficult to identify because it remains within the spermatic cord for the males and the down ligament for the females. So instead of identifying the nerve, if we have to block this nerve, we usually go to the spermatic cord and we block at this point. So from the anterior side, these three nerves, among which the femoral nerve is the most prominent nerve, will be able to identify. Then we are having the lateral femoral cutaneous nerve. Then we are having the femoral branch of the genitofemoral nerve. Then we are having this genital branch of the genitofemoral nerve. So identifying these nerves is very much essential. Now, as we go into this more medial portion, I'm just hiding what is not required. Okay. So here we have the pectineus and here we have the adductor longus. I am just hiding the adductor longus. Here we will be able to see the branches of the obturator nerve. So remember, if I do a little bit undo, you will be able to see this nerve is actually, I am hiding again, actually situated in between the adductor longus and adductor brevis. Okay, so within this muscular plane, we will be have to block for the obturator nerve. If we even hide this adductor brevis, then over this connection, there are branches of the obturator nerve. There also goes. Okay, so posterior branch also goes through this adductor. This I am hiding. Adductor minimus is not identifiable. So this portion, that is the posterior branch, we will be able to see the in between the adductor magnus and adductor brevis. So we have the anterior branch between the adductor longus and adductor brevis, and the posterior branch between the adductor brevis and adductor magnus. So anterior nerves are clear to you? Any question? Anyone is having any question regarding this anterior nerves? Or if you want me to repeat any portion, because this we will be seeing and it is important for our pain procedure part. So anyone is having question, I am ready to repeat. If you have understood, I will move forward.
Sir,
Can you-
iliotibial tract is a tendon or any connective tissue?
It is not a tendon. It is a condensation of the deep fascia. That is a connective tissue. Clear? It is not a tendon.
Can you repeat, sir, the muscles of the very fast, the anterior side of the hip?
Okay, fine. I'm just repeating because I know it is a little bit difficult. So I'm going back into only the muscle portion. Let me show you first. Okay. So if we look at the anterior portion, the most important muscles are the iliopsoas. So this is the iliacus, this is the psoas major. And iliacus has two fibers, some fibers are the lateral fibers, and there are medial fibers. Then we have the psoas, there is psoas muscle, and at this point under the cross section, we can see the psoas tendon as well. So if you hide this iliopsoas, then we are having the portion of the femoral head visible, And from the anterior superior iliac spine, we are having the sartorius, which above attaches with the anterior superior iliac spine, and below they attaches with the portion of the tibia, medial part of the tibia, as a part of the pes anserine tendons. Now, from the anterior portion of the iliac crest close to the anterior superior iliac spine, the muscle taking origin is the tensor fascia lata. Then we have the gluteus maximus, and below, slightly inferior or deeper to it, we are having the gluteus medius. These muscles are attaching to the iliotibial tract, which is the deep fossa condensation, and it's a connective tissue which is going down and going attaches below in the upper part of the tibia. Okay, in a portion that is known as the Gardner's tubercle. Anyway, so let us move to the anterior part once again. Now we are having this quadriceps femoris, not quadriceps femoris, but this portion is the rectus femoris, part of quadriceps femoris. So rectus femoris attaches with the anterior inferior iliac spine, hiding the anterior inferior iliac spine and the sartorius. Now we have the medial muscles, and here we have the pectineus. Then we have the adductor longus, hiding this. Then we have the adductor brevis, and below the adductor brevis, we have the adductor magnus. So these are the muscles of the anterior portion of the hip joint. And definitely we have the gluteus maximus, medius, and if we hide the maximus and medius, then we will be able to see the gluteus minimus as well. And posteriorly, we have the piriformis. Then we have the gemellus superior. Then we have the obturator internus. And we are having the gemellus inferior. And this is the quadriceps femoris. So the posterior muscles, just don't try to remember now because we will be discussing again and again. And can you name this muscle? What is this muscle? From posterior side, I have told that this posterior side originating the obturator internus. Then from the anterior side, it is the obturator externus. Okay. But it's a deep muscle and we do not require mostly because not the pathologies are not important, pathologies are not there. So we ignore the muscle sometimes. So these are the muscular portion and nervous portion we have already discussed. So hope you have understood the anatomy, and now we'll be moving towards our presentation. So this portion I'll be going first because the anatomy portion I have already covered. So just today we'll be covering the anatomy, which I have already covered with the 3D anatomy. Then we'll be discussing the sono anatomy, and then we'll be discussing the most common and few uncommon causes of the hip pain, evaluation under ultrasound, and ultrasound guided interventions we'll be discussing a little today. Okay, so coming to the hip anatomy, quick review: femoral head, femur, pelvis, and the iliac bone. I have covered everything. Then we have the muscles. Here are the important muscles: psoas major, iliacus. You can see in color, green is the iliacus, red is the psoas major. They are having the common insertion of the lesser trochanter of the femur. Now moving towards the posterior side, we have the gluteus maximus, gluteus medius, and gluteus minimus, I have already told. And we have the tensor fascia lata slightly towards the anterior side. This is the gluteus maximus, arising from the margins of this big origin, and below it is attached to the gluteal tuberosity of the femur. This I have already discussed while we are discussing the osteology. Then we have the gluteus medius, which is taking origin from again to the posterior part of the ilium between the anterior and the posterior gluteal lines, and they are inserted into the lateral aspect of the greater trochanter of the femur. Similarly, we have the gluteus minimus that is taking origin on the gluteal surface of the between the anterior and inferior gluteal line, and it is attaching to the anterior aspect of the greater trochanter of the femur. Then we are having the tensor fascia lata muscle, which is taking origin from the outer lip of the anterior side of the anterior superior iliac spine and taking attachment at the iliotibial tract. Then we have the small muscles, small deep muscles. Sometimes there is a pain, it is known as the deep gluteal syndrome. So we have the piriformis muscle, we have the obturator internus muscle, then we have the gemellus superior and inferior, and we have the quadriceps femoris muscle. Now, I'm not going into the piriformis or the deep muscle, posterior muscles in detail because we have to cover the lot of part in the anterior part. Next class, we will be discussing most of these inferior camellus, quadratus femoris and all the muscles. Now, most important is the muscles of the thigh. As I told, the sartorius taking origin from the anterior superior iliac spine and getting attached in the lower part in the along with the pes anserine bursa, pes anserine muscles. So it is attaching to the medial part of the upper part of the tibia. When we have the quadriceps femoris, they are the 4 in number. The most important here at the hip joint is the rectus femoris, taking origin from the anterior inferior iliac spine and getting attaching to the upper part of the patella. Then we are having the vastus medialis, lateralis, and intermedius. And there is a small muscle articularis genu that we'll be discussing with the knee, not now. And in the posterior part, we have the muscles of the hamstrings. They are the biceps femoris, semimembranosus, semitendinosus. They are purely the posterior muscles. So we'll be dealing on those muscles in the next day. In the medial portion of the thigh, we are having the obturator externus, I have shown you. Pectineus, I have shown you. Adductor longus, brevis, magnus, and sometimes the adductor minimus. Gracilis, minimus also I have shown you. And gracilis also I have shown you. So these are all the origin and insertion of those muscles. On this slide, I will share along with the write-up. So don't worry, you don't have to write. Now in the barsas, again, I have already described this. This is the ischiogluteal barsa that might be inflamed, especially if there is a cancer and the patient suddenly loses weight. And in case of the spondyloarthropathy patient, this ischiogluteal bursitis could be another very big problem, and the patient is having difficulty in sitting. Okay, and this is a very difficult situation to manage. Then we have the iliopectineal bursa in the anterior side, and this bursitis can cause another condition that is known as the snapping hip syndrome. So the internal and external rotation of the hip might cause a snap sensation and pain. And here we can see the iliopectineal bursa as well. Okay, so we are having the iliopectineal bursa. Remember, this bursa I have told you that this bursa can give rise to this snapping hip syndrome. Okay, not this one. Okay, be correct. Now, ligaments already discussed. I am not repeating the ligaments once. Okay. Now the capsule. The capsule have a typical character. I have not gone into detail, but you have to learn about this capsule. Remember, two structures along with the bone what we have seen, the moves anterior and moves farther. One is the labrum, other is the capsule. Now, this capsule is having a typical nature. So what it does, when we see like this, remember the capsule do not directly attaches. Rather, this forms infolding. How this forms is infolding, that is very interesting to see. That this capsule is coming like this, then it is going anterior side attaching like this. So basically, there are 4 layers of capsules at this infolding portion. So 2 are the anterior layers and 2 are the posterior layers, and below remain the cavity. And this typical structure gives a opportunity for us that if there is the hip joint fusion, it is usually comes to this infolding portion of this hip joint. So except for one situation, if there is hip joint effusion, you will always be able to see fluid in this capsular infolding from the anterior side. So that's a big advantage. So which is exception? I told if there is a postoperative case, in postoperative cases, there might be effusion without fluid at the level of this joint capsule in the anterior side. But rest in all cases, even there is a slightest fluid, you will be able to absorb this fluid at this point. Okay. So let's move. So this capsule is very, very important. Now, plan of ultrasound examination. While doing the ultrasound examination, we can take this way. That is, we can first will be going to the anterior side, lateral, posterior, then medial. But remember, there is no fixed rule. If the pathology is more towards the medial side, you can go the medial examination first, then you can come to the anterior side. So now today we will be discussing the anterior portion and the medial portion examination. Now, how you can place the patient for the anterior portion examination? Remember, for the anterior portion examination, we will take the patient or place the patient like this picture. That means a little bit difficult and a little bit uncomfortable for the patient. So you have to be very careful, assure the patient, and try to hide definitely the private parts and expose only the area that you need to examine. Okay, for the anterior portion. So today, first we will be examining like this, then we will be moving towards the medial part. So while seeing the medial part, you can ask to flex the knee and then do some external rotation so that we will be able to see the medial structures better. And that is how we will be examining the anterior and medial portion of the hip joint. So patient positioning is very crucial, vital, and I will try to ask you to remember these two positions for the anterior and the medial portion of the knee joint. Now we can start scanning in this manner. In fact, for the beginner, when we have started, we have used to do like this to find out the neck. First, we start from the proximal femur, then we move up, and then we go towards the lesser tuberosity area. Then we move towards the greater tuberosity area and the neck part of it. But remember, while you are practiced, so this will come with time and with practice. That now, most of the time, we start with the joint, the hip ball, to find out this hip, this head of the femur first. So here is the head of the femur. This is the neck of the femur. And as I told, there will be the muscles over it. So in the medial portion, what is this muscle we are expecting in the medial portion? This muscle, not one name, just take the whole name of this muscle.
Iliopsoas muscle.
Iliopsoas, very good. It is not clear. It is not a very clear picture of iliopsoas, but we can say this here is the iliopsoas. And next we have here the rectus femoris muscle. Okay, because it is below the anterior inferior iliac spine, so rectus femoris have started. And here we have the sartorius muscle. Clear? So we have to be clear about our muscle disposition at this point. Again, I will be showing you while I am scanning. Now we can go further medially, further laterally to find out other muscles and other structures here. Now we can, this is the area that we need to see carefully, that this is how it looks in a good picture. So we'll be able to see the portion of the neck, we'll be able to see the portion of the neck, portion of the head, portion of the acetabulum, portion of the labrum. See, in other pictures, we have not shown you the labrum, but in this picture, you will see, we can see the labrum as well, because here this bony portion is the acetabulum, and there is a projection of a hyperechoic area that is going anteriorly. This portion is this is the labrum, but sometimes labrum is here, and usually the psoas tendon remains very close to the labrum. So it becomes a little bit difficult to differentiate between these two structures. There is always a black line if you carefully examine at this point. Okay, so psoas tendon and labrum sometimes gets a little bit difficult. Here we are having the enfolding of this joint capsule over the neck, and here we will be able to see the rectus femoris and sartorius. So if you have to find out the elliptian, what we will search for the elliptian at this point, okay, but not at here at so below, but above at higher level, okay. But you have to know these areas where to search for which structure. Okay, moving towards the short axis of this iliopsoas tendon, we can say close to the head. I have told you sometimes it becomes very difficult to differentiate these two structures. That means this portion is actually the labrum portion, this portion is the bony portion, and here we have the psoas tendon. So this is the psoas tendon, and over we have the psoas muscle. So we have to identify this by careful scanning. Now moving further, then more medially, definitely we will be able to see the some portion of the pectineus if we go medially, and if we look at the level of anterior inferior iliac spine, we will be able to see this structure. So basically, from the head area, here in this picture, from the head area, we have moved towards the medial side. Okay, medial and superior side like this. The arrow is already given. I am not drawing. So here my probe is like this. Okay, so here we are seeing the anterior inferior iliac spine, iliopubic eminence, and we can see the tendon. Okay, this is tendon is the psoas tendon, iliopsoas tendon. Can anyone tell? This is a very good name for a block. Can anyone tell what is the name of this block? This is the anesthesia question in question.
Pinch
Paying
block.
block. Very good. This is the paying block. From lateral to medial side, you can come and just posterior to tendon, you have to inject, and this is known as the paying block, which is given post-operatively following a hip surgery for a post-operative pain relief. Okay. So this is the paying block, and here I will, because the branches of the lumbar plexus, they will be moving from this area. And in fact, you know much better about the paying block. I am not going to much detail of it. If we go further medial, then sorry, before that, there is one slide of the joint diffusion. So I am just repeating what I have showed you in previously, because in joint diffusion, as I told, there will be two foldings. Okay, so this is one layer from above. This is outer layer, and here will be inner layer like this. There will be four layers, okay, of the joint capsule. And what happens when there is fluid in the hip joint? It comes in between these two layers. Okay, among these four layers, in between the second and third layer, there will be collection of frequency and echoic area. This is how you can know this is a hip diffusion. So you can aspirate, you can send for culture sensitivity routine examination, and if required, if it is a non-infective case, you can inject for steroid here as well. And that we commonly do. So this is the area. This is one of the procedures in the hip joint most complicated. So we have to learn this technique and finding out this area and needling this area as well. So if you want to needle, you can come according to your convenience from the medial or lateral side. But obviously coming from the lateral side becomes a little bit easier because there are no important structures there. Now, here it is a condition where there is a pigmented filonodular synovitis of the same area. So there is no fluid, but again it is showing hypoechoic area and erosion of the head and neck. Okay. Now, coming to the labrum. The labrum you have seen in previous pictures. Now, within the labrum, if we see some black tear. Okay. So see, here are the tear. Okay. This is a portion of the labrum. Again, this is a portion of the labrum, and in between there is a tear. So this is a labral tear. So that might happen in a degenerative case, and this is quite common. While when actually the femoral head has become irregular. Okay, injury might cause it. There might be another condition that is known as the intra-articular snapping hip syndrome that might give rise to this condition. Okay, and here you can see there is chondrocalcine calcinosis, and there might be cyst formation around it as well. Okay, so these are all labral pathologies, but again remember, only the peripheral labral pathologies could be identified by the ultrasound. Okay. Again, there are paralabral cysts sometimes that occurs as a part of the hip degeneration, and that is an anechoic and sometimes hypoechoic multilocular cyst that is observable as a labral pathology. Now, today to understand what is snapping hip syndrome, we have to understand there are three syndromes basically. They are all together called a snapping hip syndrome. Okay. One is the internal snapping hip syndrome. So here the basic is all three areas is the same. You are moving from to the internal rotation to the external rotation, and there is snap of the hip. Now, internal snapping hip syndrome is basically within the iliopsoas tendon. Okay, and when the tendon is scratching over the iliopectineus eminence, if there are two theories basically on this. One, it is snapping over the iliopectineal eminence and it is stuck somewhere and then it moves. That's why this snapping sensation occurs. And some says that, I'm showing you this picture because this is also very good example of the snapping here. Okay, yes. Some says there is another pathology. Might be in some cases one pathology is there, in some cases other pathology is there. This tendon, while moving over the muscle, so it moves within the muscle and through the muscle, it just drops here. Okay, that means up to certain portion of the rotation, this tendon is over the muscle, the iliacus, iliopsoas, this tendon. Okay, psoas tendon. And when we are moving from this area within the muscle, it just drops over it, and this causes snapping syndrome. So both the theories are there, and it might be associated with the bursitis at the iliopectineal bursa. Okay, so this is what is known as the snapping hip syndrome, and this is the internal snapping portion of the snapping hip syndrome. Now, coming to the external snapping hip syndrome. So in the external snapping hip syndrome, sometimes it is called the upper iliotibial band syndrome, where the iliotibial band, typically the lower iliotibial band syndrome, I have told you, it is the iliotibial band having friction over the greater femoral condyle, especially the lateral femoral condyle. But here, in the upper iliotibial band syndrome, this portion of the iliotibial band that is actually scratching over the greater tuberosity, and that is causing pain there, and again it is causing the snapping. This is known as the external type snapping hip syndrome. So pathology, clinical finding is the same, but here the pain will be at the external side. And third type of snapping hip syndrome is this one, where it is known as the intra-articular snapping hip syndrome. Again, intra-articular snapping hip syndrome may be of two types. One, where there is deep acetabulum, and for that, this labral portion of the acetabulum, which is loose, and they get snapped within the head and this acetabulum. So portion of the labrum, because of the deep labrum, are getting trapped inside. Okay, and these are causing, because of the loose body or labral tear, and this is caused the intra-articular type of the snapping hip syndrome, type 1. And there is another type 2 also, where there is the broad base, but due to degeneration, the femoral head itself is irregular, and that is causing friction over this area, and they are causing snapping hip syndrome. So I think it's a bit complex, not complex, but is it difficult to remember? So I'm just repeating, there might be three types of snapping hip syndrome. One, where it is because of the internal snapping hip syndrome, that is within the iliopsoas tendon. Again, there are two theories on that. That is, in internal snapping hip syndrome, one, the tendon is moving over the iliopectineal eminence and stuck there, causing sound. That is one type of snapping hip syndrome. Number two, there might be another condition when this tendon, okay, is stuck within the muscle and suddenly dropping over the muscle. That is causing another type of snapping hip syndrome, that is known as the internal type of snapping hip syndrome. You can say type B of snapping hip syndrome. And the third type, where another phenomenon occurs, that means here it is the external snapping hip syndrome. Okay, then one comes the, so first remember, one is the over the psoas tendon, that is one type of snapping hip syndrome. Then it is over the outer side, that you can say also iliotibial band syndrome, that's a type, again a type of snapping hip syndrome. And there could be another type of snapping hip syndrome, that is where it is actually within the articular area. In articular area, there are also two types. So one is deep acetabulum, portion of the lateral edge, they are getting stuck between the head and the acetabulum, that is known as the one type of the intra-articular snapping hip syndrome. In another type, the head itself is degenerated, base is broad, but because of the irregularity of the head, it is stacking on the margin of the labrum, and that is causing another type of the snapping hip syndrome. So altogether, there are 3 types, but 2 types having 2 subdivisions, 2 opinions why this is happening. So I think you have understood this snapping hip syndrome part, or any confusion still remain? Hope you have understood. Okay, anyone wants to repeat me? The same thing? Or I can go forward? Say yes, no, something you say. Hello?
Go ahead, doctor. Go ahead.
Okay,
Everything
thank
is
you,
good.
thanks a lot. Because I have repeated it twice. I do not want to repeat because I have to show the structures again as well. Okay? So this is the iliopsoas. I'll be showing it on the volunteer. So, but again, you see this clearly. This portion is very, very important because here in the iliopsoas, we see what we see clearly at this portion are like this. So these are the medial fibers of iliopsoas. This is the psoas major tendon. Then we see the lateral fibers of iliopsoas, and here we see the rectus femoris, and again we can see the sartorius here. Okay, so these are the structures we can see. Let's go further. Go ahead. The same structure in the long axis. This part we will be showing you in the volunteer. Snapping hip syndrome, iliopsoas. I have covered this portion. And lateral femoral cutaneous nerve. Again, I'll be showing it. In most of the cases, it remains between these 2 muscles. One is the tensor fasciculata and sartorius. So this is the area where we will be searching for the lateral femoral cutaneous nerve. Okay. Okay. This is the sartorius, rectus femoris, iliopsoas. Okay. So we have to move slightly towards the lateral side. And then we have to move up and down slightly. And we have to focus in this area. You can see this is the nerve here, this point. Okay. And this point we'll be able to see the hypogoic. Sometimes honeycomb pattern is also observable. We'll be able to see the lateral femoral cutaneous nerve. Here it is. Okay. So that is how we have to identify this lateral femoral cutaneous nerve. Now, this is also important, is a femoral neurovascular bundle, but very simple because you are, as an anesthesiologist, you are doing this and seeing this every time. So I'll be showing the volunteer and going further. Again, the femoral neurovascular bundle, rectus femoris long axis, and here I think again rectus femoris tendon, TFL sartorius. I will cover while seeing in the medial hip portion. We are having the adductor tendons in the short axis. One side it will be the pectineus, and below we'll be able to see the adductor longus, brevis and magnus, and these are the areas where we have to search for the nerves. So this is one area, this is the another area. Okay. So in the adductor portion, finding the obturator nerve branches are very important, anterior, posterior branch. Again, sometimes divided further. So if we put the probe like this, the same picture here. So if we are putting the probe like this, the portion of here, this area, here we can see the, this is the pectineus muscle. Then we are having the adductor longus, then we are having the adductor brevis and the adductor magnus. And here we can see the junction between the adductor longus and brevis, and this is the between the adductor brevis and magnus. So here we will search for the anterior branch, here we will search for the posterior branch. Sometimes they are visible if the machine, your machine is very good. Sometimes they are not visible, but there are no issues because always this plane is visible. So like a plane block, you have to inject here. Even if nerve is visible, there are multiple branches, not always they are single branches, sometimes they are divided. So you have to block in these two planes. Okay. So obturator block, and this is another pathology that we need to know. That is, sometimes might be there that the adductor longus tendon is already snapped. So it's a complete tear of the adductor longus. Then you can see from the proximal end of the pubis, the tendon is detached and they are forming and there is retraction at this point. So these are the pathologies we need to find out. Okay. So finally, I'm showing you a few structures and they will move back to the so I think concepts are clear for you right now. Anatomical concepts are clear now. So first I am showing again few slides and then going forward for the volunteer demonstration. So this anatomical part fully covered, muscles fully covered, iliacus was fully covered. Now it is the labrum portion identification. So this is where we have put. So this is actually made for you so that it is much clear to you. Even before the volunteer scanning, you will be able to identify the structure. So this is our most important area, that is finding out the femoral head and femoral neck. Okay, so this is the femoral neck portion. This is the iliopsoas tendon portion. So we are focusing the probe in this manner. Okay, so this step is very, very important, and here in this way we'll be going for this. Okay, so if we go slightly medially, here you can see that there is a differentiation between this. See, at this point, there is a definite differentiation between this labrum portion and tendon portion also. Okay, actually, see here at this point, you can see there is a differentiation between this is the labral portion, this portion is the labrum portion, and here it is the tendon portion. Okay, and this is the bony portion. This identification is crucial, and we have to know this. Next, this is the labral portion. Next, the capsule folding. To see the capsule folding, you have to focus at this point, adjust your focal length and the gain accordingly. You will be able to see this infolding at this point. Okay, so here is the infolding portion. This is a normal volunteer, and the circumflex artery is sometimes visible at this point. You can see that circumflex artery as well. Now, the movement to the greater trochanter neck from below. So here you can see the femur, and if we move up, then we'll be going up to the greater trochanter like this. Next is the iliopsoas. So here, as I told, here is very, very important. Okay, this is the sartorius, this is the rectus femoris, this is the tensor fascia lata. Okay, and below will become the glutei. Again, moving towards the psoas tendon and psoas muscle. So if we look at this point, okay, I'm just showing you. Here it is very important and very beautiful picture of the tendon. And here I am just showing this because here with the scanner, this pictures will help you a lot. So this is the, you can see this is the psoas tendon, hyperechoic tendon. This is the psoas tendon. Then these are the psoas, okay, medial fiber, lateral fiber. They are the iliacus, and this is the portion of the psoas. Okay, to identify these structures, this is very, very important. Okay, and medially there will be the neurovascular bundle. You can see the femoral artery. Veins you are not able to see because of the compression, and here is the femoral nerve. At this point, you can see the nervous structure, honeycombing pattern, and this is the femoral nerve. Again, closer look at the iliopsoas tendon. You can see this how clear this psoas tendon is visible. And again, these are the medial lateral fibers of the iliacus, and there is the fibers of the psoas, muscular fibers of the psoas. Okay. And here, if you move, you can see the anterior superior iliac spine here. Okay. Going further forward. Okay, here we can see the attachment of the rectus femoris and the sartorius. So rectus attaches first to the anterior inferior iliac spine. If you go further up, then this sartorius again will get attached. This is the sartorius. It will getting attached to the anterior superior iliac spine. So from below upwards, if you move, initially it will be the anterior superior iliac spine. I am showing once more. This rectus will attach to the anterior inferior iliac spine, and then sartorius will move to the anterior superior iliac spine. While I will be scanning, I will be asking questions, okay? So that it will be clear for you. Okay, this is the anterior superior iliac spine where it is getting attached. So next is the adductor muscles. To see the adductor muscles, see the limb position. Limb position should be placed like this. Then we have to see between these two planes. So above it is the adductor longus, then we have the adductor brevis, then we have the adductor magnus, and in the other side we'll be having the pectineus. Okay, and within this line, sometimes we can see these vessels and nerves, and they are branched from the anterior part branch of the obturator nerve, and here it will be the posterior branch of the nerve, obturator nerve, and this is the pectineus muscle. Okay, going further. Okay, so these are the attachment of the muscles at the level of pubic symphysis that you can see. If you go medially, they will attach to a bony point, and that is the pubic symphysis. Now for the paying block, I think this I have shown you previously. I'm not going, you have to focus clearly where you can see the base portion. Okay, you will be able to see this pubic eminence, then anterior inferior iliac spine, and here we will be able to see the iliopsoas, and below the psoas major tender, you have to go for the paying block. So you can see this is the anterior inferior iliac spine, this is the area of the above the anterior inferior iliac spine towards the pubis. So through the superior pubic ramus, over which the psoas tendon is going. Okay, and below, obviously, medially there will be the femoral nerve and femoral vessels. This is the femoral artery and this is the femoral nerve. Okay. So lateral femoral cutaneous nerve, as I told, it goes below the inguinal ligament. Then it remains between the sartorius and the tensor fascia lata, and this is the area where the entrapment is common. And if you want to do the dextrose mediated dextrose carried hydrodissection by dextrose, you can target the LFCN at this area. Femoral nerve, I think this is the easiest nerve to find, and it is very simple. Okay, so it will be medial to the artery, sorry, lateral to the artery, and you will be able to see the nervous structure. LFCN, sartorius, going lateral to the sartorius. So we need to search at this point, lateral side of the sartorius. See, here it is. Femoral branch of genitals I am showing. Okay, let's come. I think I have discussed this again and again, and it is clear to you. And last slide, it is very important. This is the snapping shift syndrome. Okay, as I told, there sometimes may be an internal snapping within the tendon. So this is a very important picture where you can see this internal snapping that is occurring within the that I have told the muscle and tendon. They are moving, and one is snapping over the other. This is the internal snapping within the iliopsoas tendon. Okay, so theoretical part you have all understood.
Yes.
Okay.
Yes,
Now,
sir.
let's start the demonstration. Demonstration will not take much time because now you have understood the anatomy clearly. I'll be asking, and you have to answer. এটা ছবিটাকে ছোট করে দাও, মিনিমাইজ করে দাও ছবিগুলোকে। Hello, can you hear me?
Yes, sir. We can hear
Yes,
you.
sir.
Okay, fine. So this portion is towards the hip joint, and this portion is towards the knee. So you can understand how the volunteer is on the bed. And now, as I told, first I am putting the leg in a straight way. So, how to do this? So I think now you can see this portion is the knee portion. This portion is the hip portion. Only expose the part where you have to do the procedure. This portion is the lateral portion, and this is our lateral side of the index marker. So this is the index marker. It will come towards the left side of the screen. So now I am just holding the probe like this and unfreeze. So we have to first identify the bony structure. So one bone we can see, I am letting depth slightly increasing the depth, slightly reducing the gain. So we can see one bone here, and definitely it is the femoral shaft in cross section. I am moving up now Okay. And as I moved up, I have reached a portion where we can see a portion of the femoral head. Still, my probe direction is not along the neck. Slightly my lateral portion is up. So once I have reached the head, my next job is to lower down the lateral portion so that I can able to see the neck of the femur. So I need a little more of gel here because the lateral portion is losing. Okay. So as I am coming to this portion, here you can see the junction of the head and the neck of the head. And remember, this picture is very, very important because whenever you find a new fusion, you will be finding at this point. So let me freeze and let me show that here is the head, here is the neck, and this is the infolding of the capsule at this point. So if there is fluid, the fluid will be accumulated at this point. Clear? Where I have to suppose to draw a straight line, it has become very, very bent. So this is the portion the first picture, or you can say this is the first learning. You should first see this structure. Now we have understood which portion is the head, which portion is the neck. So after finding this structure, we have to find out the rest, that is the psoas, iliacus, and the acetabular portion. So from this area, from where we are at the lateral side and we are seeing the neck, I am moving slightly towards the medial portion. And slightly towards the medially, we can see this portion. Let us stop here. I have to call it up. Okay. So this is the bony portion, and here it is the labral portion, and this is the tendon portion, and this is the iliopsoas portion. Let us do one thing. Instead of this curvilinear probe, let us take the linear probe so that this anatomy could be on a high resolution and more clear. The question? So here also I am following the same orientation. That means I will keep the index marker towards the lateral side. Okay. So here we are close to the head. Okay. And here we can see the portion of the iliacus. Ini pada share pernah. Best vision alpha. Mhm. Okay, now it is much clear. Okay, so medially we have the bony part, and now I am just toggling to see the more white portion of the tendon. Okay, so let's move to the from that area. Let us move towards the lateral part so that we can see the other muscles. At the top, we can see one triangular muscle. This muscle is the sartorius muscle. Sartorius talk about that. Tomorrow sartorius. So this is the sartorius muscle. And below the sartorius, we can see a small muscle. Right side, it is the iliopsoas. I'm taking iliopsoas, but lateral portion is lateral fibers of the iliacus, more correctly. Okay, here we have the rectus femoris. Okay, the small portion is visible, and if we go farther lateral, the muscle will be able to see. Here we can see is the tensor fascia lata. Okay, so we have able to see the rectus femoris, sartorius, and tensor fascia lata. Now, from this area, I am moving up to show you that the rectus femoris muscle, see, just follow the rectus femoris muscle. Okay, just draw a dot over the rectus femoris. Yes, they will be following, so don't make it. Okay, follow this muscle. I am moving the probe up, and you see this rectus femoris muscle is attaching to a bony part. So at this till this portion, you can see the rectus femoris, but over that you can see only a bony part. So what is this bony part? Can anyone tell?
Anterior, inferior.
Anterior.
Anterior,
Very
inferior.
good, very good, very good. This is the anterior inferior iliac spine. Now, sartorius is still visible above. Can you show the sartorius ones? Now, from this point, I will further move up. So, see, sartorius again is getting attached with another bony part. I am just coming down to show you once again. See the sartorius you can see now. The triangular sartorius, I am reducing the depth for you, so it will be easy, okay? So that you will be able to see large sartorius. So sartorius is visible now, the triangular muscle above. As I am moving up, just try to follow the sartorius. Now it is again becoming attaching to a bone. So what is this bone?
Anterior superior.
Anterior superior spine.
That is the best part, because we have learned the anatomy so well today that now you are able to tell these structures. Now, if I go laterally, what is this muscle?
Tensor fascia lata.
Yes, fine. As I told, we have a nerve in between. So we have to see in between these two muscles. Okay. So you can see a nerve there. Dr. Roy has already drawn. So what is this nerve?
Lateral femoral cutaneous.
Very good, lateral femoral cutaneous nerve. So now it will not be a difficulty to find out the lateral femoral cutaneous nerve. Now again coming back, and we are seeing the sartorius. Then again we are seeing the large portion of the iliopsoas. Now I am moving towards the medial side. And here we can see the neurovascular bundle at the medial side. I am reducing the gain slightly so that it is much easily visible. Okay, so this portion is, you can see this nervous structure which is lateral to the artery, and this nervous structure is the femoral nerve. Very easy to understand. Now, can anyone tell why there is whitish structure below this artery? Why this is so white?
Acoustic window, sir.
Yes, it is the posterior acoustic enhancement. That means within the artery, there is no echo to get reflected. Echoes are not getting reflected. So these echoes are getting accumulated below, and from there, large amount of echoes are reflecting. That is why it is a type of artifact. Okay, and this is known as the posterior acoustic enhancement. Now, as we are moving close to the artery, we have to try to find out a nerve close to artery. Yes. Hmm. Actually. দেখতে তো পাচ্ছি কিন্তু। So now, in between the artery and the vein, okay, try to see a nervous structure there. This is the, see, now it is clear. The femoral artery, femoral nerve is at the lateral side, but slightly medial to it, you can see the which nerve? Oh, Chimada has already written. So you can easily say that is the femoral branch of the genitofemoral nerve. Now you are left with one nerve we have seen, that is the femoral nerve of genitofemoral nerve. Then where is the genital branch of the genitofemoral nerve? So it is with the spermatic cord. So how to find it out? Let us see. Now you can see femoral artery. So at this point, I am making, this is my index marker. Block হয়ে গেছে মনে হচ্ছে, দেখা যাচ্ছে না?
Sir, the probe the probe movement
Probe is
not
frozen.
possible.
Yes, I can see. Because I am showing you, it is not being seen. So that means probe is frozen. Let me do one thing. One second. Let probe. আমার ওখান থেকে গন্ডগোল আছে এখানে। অন্য কোন সফটওয়্যার আছে? এটাকে রিস্টার্ট করো, মোবাইলটাকে রিস্টার্ট করো। Just 1 minute, we are trying to solve it. The field posted into a port. Okay. Now it is acting. Just 1 second. Okay. Okay. Yeah. Okay. Now, hello, can I see? A little flicker is there, I can see, but I think it is appreciable still.
Yes, sir. I can see.
So
Sir,
now
can you
what we are
try
doing,
the femoral branch of genitofemoral again, sir, because the screen froze, so we were
hello,
not able to see the probe movement.
hello,
Yes, tell me. Sir, can you repeat tracing the femoral branch of genitofemoral nerve, sir?
okay, femoral branch of the genitofemoral nerve. It is actually femoral nerve, you can see clearly. Now you just go slightly towards the medial side and try moving up. See, one nerve you will be able to see between this, close to the femoral artery. Okay. Yes, 1 minute. X. Yes. So following the same orientation, that means index marker is in the see close to the artery. You can see one nervous structure there. Okay, so in the lateral side, this is the femoral nerve, but here in the other side of the artery, you can see another nervous structure here. Okay, so here below is the vein. So this is close. Here you can see. I'm stopping here.
Yes, sir.
Okay, I have stopped it. Now you can see one nervous structure there close to the artery.
Yes, sir.
Hello.
Yes, sir.
Okay, that is the femoral branch. Now again I am focusing on the artery, and now we are making it along the direction, along the long axis of the artery. So we can see the femoral artery now, and now we are making it along the long axis. So I am putting the index marker towards the cranial side. So now as we are following the artery, just 1 second, somehow I lost. Okay, so yes, you can see some structures, okay, at this point where the artery is dipping down. I'm just stopping at the correct position, then it will be easier. Okay, so see, when the artery is dipping down, you can see some of the, not only here, there is the vas deferens, there is the arteries, and this is the spermatic cord. So if you cannot separate between from those structures the genital branch, but usually it is given at this point. Clear? So the principle is go to the femoral artery, change the direction to 90 degree, move up while the femoral artery is dipping down superficial to the femoral artery. You will be able to see this neurovascular structure. Okay, so we have identified the LFCN, we have identified the femoral nerve, we have identified the genitofemoral, medial, genital, and the femoral branches. Now we will be moving towards the adductor compartment. So For the adductor compartment, as I told, we have to flex and external rotate the leg. Now at this point, we are just trying to focus at this. See, we can see at this point, we can see two intramuscular. We have to use a little more gel. It is not enough. Hmm. Pectineus. So this is the first muscle. You can see pectineus. Pectineus is clear to you at this point, or should I increase the a little, increase the gain a little? Now you can see the pectineus, large pectineus you can see here.
Yes,
Yes,
sir.
sir.
Okay. So okay. Now I am moving from the pectineus. I am moving towards the medial side, so that we can get a fascial plane between two muscles. Let us now, fine. I'm freezing here. So can you see three muscular layers? In the most left side, we have the pectineus. Above, we have the adductor longus. Below, we have the adductor brevis, and further below, we have the adductor magnus. So in between these two planes, we have to find out the anterior and posterior branch of the obturator nerve. But remember, there are not only two branches, they become multiple branches at this fascial plane. So again, it's a fascial plane block, not a exactly nerve location is not always possible. So this is how we'll be blocking the obturator nerve. So any questions regarding any part? No question. Actually, we have taught the anatomy so beautifully that now while demonstrating, it has become much easy. So
Excuse
I
me, sir.
think we can conclude today. Yes.
The
Yes,
site of
please.
injection, the site of injection for the intra-articular hip injection.
Yes, I have told you for the intra-articular, we usually go to this junction at the neck and the, I'm again showing you, okay. So this is the most important structure in identifying when we have to identify the head and the, I'm increasing the depth a little. Head and the neck. Identifying this junction is crucial, but the head is meeting with the neck. Okay. Here we can see the position to take position of track pay, position reversible, position of experience. এটা দিয়েও আসবে আসবে 20 আসবে. Okay, so here we can see the head, and this is the labrum. This portion I have already shown you, but again showing here you can see even from the previous picture this is coming better. So this is the portion of the iliopsoas, and it is at the junction of this acetabulum. Now I am going towards the lateral side, and we have to keep the medial part over the head, and lateral part we are trying to find out the neck. Okay, here we are in the neck portion, but I think as it is a deep portion, it is not that clear as it is supposed to be. So let us take a deeper probe. Here we have the neck, but it is not clear. So I am taking the other probe. That means we are taking the curvilinear probe. Okay. So finding the head first and then finding to the neck. Okay. Okay. So this portion you have identified. So for the intra-articular portion, usually it is given at the neck where the capsules are there. So we have to focus at this point. Okay. Where these capsules are joining. Okay. You can see the capsular enfolding here. I'm reducing the depth further. Okay. Okay, fine. Okay, now we can see the head and neck clearly. I am just reducing a little bit of gain. So, so now you can see the capsular enfolding. So this is the area where we have to go for the intra-articular injection, as I told. Now this is clear to you?
Yes, doctor, thank you. What about the pink block? Sorry.
Okay. Excuse me?
Pink block.
Pink block I have also shown. And in this part now, one thing, while injecting, there are some vessels here and you have to be careful. Okay, this part I have not told. They are the circumflex femoral vessels I have shown in the anatomy part, but you have to avoid these vessels. So come from a little up so that it is not going to that area. And the pink block I have already shown you once, but again I am repeating. So for the pink block, what we will do? We will first again focus over the head. Okay, we'll try to find out where is the head. Okay, here is the head. Now we are changing the probe direction and going slightly up. So from the head, we are going slightly up, and here at this portion, one side you can see the anterior inferior iliac spine. One side you can see the ischiopelvic eminence, and the hyperechoic portion, what you can see is the iliopsoas tendon. So again, from lateral to medial side, you have to put the needle like this. Clear?
Yes, doctor, thank you.
So any other questions? No questions. So I will send you the write-up of all the details. So read it and see this recording again and again. Then only you will be able to understand. Remember, the hip part is a little bit difficult part, usually considered, because here the structures are at a comparatively deeper location. So to find out, you have to be very careful. You have to change the probes again and again. Okay, take your time and try to find out the structures. Okay. So let us end for today. Okay. Bye.
Okay, sir. Thank you, sir.